All right, so thank you very much, everyone, for attending. So like Dr. Euler said, for those who don't know me, my name's Zola. I'm one of the first-year infectious disease fellows here at USF. So in today's talk, what I hope to convey are some points regarding what exactly is the opioid epidemic. I'll also define opioid use disorder as well as the risk of infectious disease associated with opioid use disorder, and the role that we as infectious disease physicians have in terms of putting to an end, so to speak, to this opioid epidemic. I'll also touch base a bit on medication assistant treatment waiver, and we'll also take a look at what's being done at a national level. So opioids, as we know, they include most prescription analgesics, as well as other products or illicit drugs from the poppy plant. They're predominantly used to aid with pain control. However, they can, produce feelings of euphoria, tranquility, as well as contribute to sedation. And they can ultimately lead sometimes to a desire for escalated doses, which can ultimately result in opioid use disorder, as well as increased mortality. So in terms of the opiate epidemic, how it really came around, this is some information I got from the U.S. Department of Health and Human Services. Essentially, in the 1990s, you had scenarios where many pharmaceutical companies stated, patients were, they were not going to become addicted to opioid pain relievers. So quite a number of providers saw that as a means of them, being able to, just prescribe them, let's just say, without maybe giving as much thought as they probably should have given at that time. So with that, it's proposed that, or theorized that led to, an increase in their use as well as misuse of not only prescription but also non-prescription opioids. And so much so that in 2017, the U.S. Department of Health and Human Services essentially declared it a public health emergency. So when we look at the timeline from about 1999 to 2017, almost 500,000 of people died from opioid overdoses. So pretty remarkable statistics. Now, this diagram here is from the U.S. Department of Health and Human Services as well. Essentially, it's some data on a survey on drug use and health that was predominantly conducted in the year 2008, and some of the data overlapped to about February of 2019. I think the key things here that I want you to recognize is that pretty much 130 plus people die every day from opioid-related drug overdose. In 2018, there are about 10.3 million persons misuse prescription opioids. In addition, around 50,000 people died from overdosing on opioids. And if we want to take a look at in terms of deaths attributed to overdosing on synthetic opioids, that was about 32,000 rather. So what exactly is opioid use disorder? Opioid use disorder is essentially the repeated occurrence within a 12-month period of time of two or more of the following. And I'm not going to read out all of the criteria there, but it's essentially what's listed in the 2013 DSM from the American Academy of Psychiatry. So you get the general theme that you have the use of an opioid in increasing amounts over longer, the desire to use it in increasing amounts or longer than it was originally intended. So the spectrum goes down to continued use despite you having negative effects from it. So you need 2 out of these 11, and it needs to be like a repeated occurrence to meet the diagnosis for opioid use disorder. And the other thing I want to hit home as well is that this affects all persons in terms of socioeconomic status. And sometimes we don't realize that. We think, oh, maybe just like homeless persons and whatnot. But no, it can affect anyone, regardless of your socioeconomic status or racial background as well. In terms of opioid-associated infection risk, I think the key things that I'd like to say is that the risk of infection is dependent on numerous factors. Some of the more recurrent factors that you see in the literature is that high-risk injection practices. So what are these? Use of, sharing syringes as well as drug paraphernalia. So as you can imagine, that's going to be a risk for, spreading infections. Also, contamination of the drugs or paraphernalia and the injection site as well. These can also contribute or increase the risk of acquiring infections. In addition, injection drug use associated sexual risk behaviors, these as well contribute to, the higher incidence of infectious disease in this group of persons or people who inject drugs. So it can lead to, transactional sex, sex with multiple partners, sex without condom use. So you get the general trend in terms of increased risk of STDs and whatnot. In terms of the more common opioid-associated infections, the ones here are what we typically talk about. So certainly there's increased risk of HIV, hepatitis C, infective endocarditis, bacteremia or fungemia, skin and soft tissue infections, as well as osteomyelitis. So now, what is the financial impact of opioid-associated infections? Well, pretty much it's a financial burden. This is probably the most recent data that I could get. But essentially, the costs related to opioid-associated infections tripled from 2002 to 2012, from around 190 million to about 700 million. And in 2012, basically it was deciphered that the average charge per hospitalization for someone who came in with an opioid-associated infection was about $107,000. And bearing in mind, the majority of these persons, when you look at the data, they're actually uninsured. So it's quite a costly condition. So opioids and HIV. In 2016, injection opioid use was said to have led to about 13% of new HIV diagnoses. So that's a significant amount. Persons who inject drugs, as we know, they're increased risk for acquiring HIV because of their drug use practices and sexual behaviors, which I elaborated on a couple slides ago. And now, in 2015, the National HIV Behavioral Surveillance System in terms of their data, they found among HIV-negative respondents who inject opioids certain risk factors which were going to actually put them at risk of developing HIV, even though they didn't have at this point in time. So what were they? They reported that of those that tested HIV negative, about 27% reported sharing syringes. So they may not have HIV now, but if they continue these practices, they're certainly going to be at a high risk of contracting HIV. In addition, about 2/3 reported, having vaginal sex without a condom, and only around 34% said that they received all their syringes from sterile sources. So again, you can see that they are at risk of, getting HIV. How many persons here know about Scott County?
Kentucky?
Indiana. Okay, so back in 2015, in January 2015, the Indiana State Department of Health investigated a cluster of about 11 newly diagnosed HIV infections in a small rural community in Scott County, which is in Indiana. Previously, in that area, they only had 5 HIV diagnoses from 2004 to 2013. So you can see they were, pretty alarmed in terms of why all of a sudden this increase in HIV cases. Turns out from November 18th, 2014 to November 1st, 2015, 181 patients were newly diagnosed with HIV in that county. Now, this is what they found. About 90% of persons reported injecting the extended release formulation of oxymorphone. And this was what was attributed or seen as the driving factor for this outbreak in terms of HIV, so to speak. And HIV infected, and when they, basically gathered more data from the persons, they found that those that were positive, those who tested positive for HIV, they were more likely to be named as a syringe sharing partner compared to those HIV negative contacts. So basically, those who tested positive for HIV, there was a high likelihood, or they were actually sharing needles amongst themselves, and that seemed to be how they contracted the HIV virus. So I think later on they found that there was actually a total of like 235 new cases when they were attributed to that extended release formulation of oxymorphone. And so it was such a, it was actually on the news quite a lot back then in 2015, and so much so that the then governor there, who's now the vice president, he actually had to declare pretty much a state of emergency there. And in terms of aiding with this outbreak, they actually temporarily had a syringe exchange program, or safe syringe program, to kind of help curb things down, so to speak. So, opioids and hepatitis C virus. Hepatitis C virus is actually the most common infection associated with injection drug use. Again, in that HIV outbreak in Scotts County, something that wasn't really reported as well. Yes, persons had tested positive for HIV, a lot of them, but actually 90% of those persons were actually co-infected with hepatitis C virus as well. So pretty much like a double whammy, so to speak. In terms of hepatitis C virus, in the last 10 years, we've seen an increase in the general USA population, and more so among pregnant women. And this has been attributed to the surge in injection drug use. Now, this slide here is from the CDC. Basically, it's just identifying that there are like around 200 or so counties in about 26 states that are at a high risk of developing or HIV and hepatitis C outbreaks, in relation to persons who inject drugs. So, as you can see, it's pretty amazing. So, did you know about 68% of pregnant women with hepatitis C virus have opioid use disorder? I think that is a very remarkable statistic. And now, this slide here is just some data from National Trends in Hepatitis C Infection by opioid use disorder status, and it's looking at among pregnant women. Is there like something that I can? It's hard. Okay. Well, it's not showing, but anyways, you can decipher that. The dotted line is for those without opioid use disorder, like the prevalence of maternal hepatitis C virus, and then when you compare it to the line that's higher up, you can see this the significant increase in terms of the number of diagnoses per 1,000 deliveries in women with opioid use disorder. It's pretty much continually increased from the year 2000 to 2015. Opioids and infective endocarditis. We're just going to talk a little bit about this. So people who inject drugs, we know there are increased risks for infective endocarditis. Worcel et al. Reported infective endocarditis hospitalizations from injection drug use increased from about 7% to 12% between 2000 and 2013. And in terms of when they did further analysis, they noted that there was a more significant increase in those in the 15 to 34 age group, as well as in Caucasians in terms of race, as well as in the female gender, though when they looked overall, it wasn't as prevalent, but it was actually higher in the 15 to 34 year old age group. Rosenthal et al., they did a retrospective review of 102 injection drug use infective endocarditis admissions from 2004 to 2014, and they found that the readmission rate was around 50%, and almost 30% of persons, of the patients rather, that were readmitted, admitted to ongoing drug use during readmission. And the rates of treatment for opioid addiction by opioid replacement therapy after hospitalization were very low in this study. So basically, what they found is that, let's say patients came in, they had infective endocarditis, we deciphered, okay, likely related to opioid, drug use. Even though we know that, not much was done in terms of, ensuring appropriate linkage to care, which would have led to like opioid replacement therapy or whatnot. So I think this is a very interesting point, which I'll elaborate a little bit further. Opioids and invasive MRSA infections. So we know MRSA bacteremia or MRSA infections, can sometimes be very hard to treat. And in fact, MRSA bacteremia, depending on your sources, can have a mortality rate of around anywhere between 30 to 50%. So the authors of this study, they sought to assess the effects of the opioid epidemic on invasive MRSA infections, taking a look at the trends from 2005 to about 2016, and they used some surveillance data from the CDC, from the CDC's Emerging Infection Program. And they found that from 2011 to 2016, the proportion of invasive MRSA cases that occurred among persons who inject drug increased from about 4.1% to about 10%. And they also were able to state that persons who inject drugs were 16 times more likely to develop invasive MRSA infections. Again, some very startling statistics. So, with all of that said, what's our role as infectious disease physicians in the opioid epidemic? I think this picture is familiar to everyone, right? Yeah. So, what can we do? What's our role? So, essentially, it's important that we recognize patients with opioid use disorder. And I'll talk about screening a little bit later down. And I think one thing to consider is, the ability to prescribe medications for opioid use disorder. So something to mention, consider obtaining a waiver for buprenorphine. There's lots of data out there that shows that with appropriate therapy, so like, the buprenorphine, methadone, you can reduce the risk of injection drug use related risk behaviors, as well as decrease transmission of HIV and Hepatitis C virus. In addition, the co-administration of opioid use disorder medication, also called medication assisted treatment, can help, or has been shown in terms of, helping improving antiretroviral therapy, Adherence, which I found pretty interesting, as well as it can also increase the likelihood of HIV viral suppression. So I think it's something worth knowing a little bit about. So in terms of screening for persons that have opioid use, that may have opioid use disorder, I found a pretty interesting screening tool called the Rapid Opioid Drug Screen Tool, which is something I think, most of the data says that it shouldn't take more than 2 to 5 minutes to actually do this. So pretty much you have 8 questions. You tally the number of yeses from 2 to 8, and if you get 3, that would be a positive screen for opioid dependence. And some of the questions are just basically asking like, have you ever taken any of the following drugs? And then it's trying to decipher, did you ever need more opioids to get, that same kind of feeling of high? Do you feel like, you're missing the fix of the drug, whatnot? It kind of, the majority of these questions kind of mirrored those in the DSM, the 2013 DSM criteria for diagnosis of opioid use disorder. But it's actually pretty quick to administer. So I think it's food for thought, something that we can know whenever we see our patients on the floor. You have an infection, you can consider administering this tool. Hopefully time permits, but I think it's something worth knowing about. So this diagram here that I have is a forest plot. Looking at the effect of opioid substitution therapy on coverage of antiretroviral therapy among people who inject drugs. It was a study conducted by Lowe et al. That was published in the Clinical Infectious Disease Journal in 2016. So, with the forest plot, the main thing you want to look at is the diamond-shaped object. And basically, what this is showing that opioid substitution therapy, or, basically like, let's say, use of buprenorphine or methadone, was associated with the 54% increase in antiretroviral therapy coverage in this particular group of patients that they were looking at, meaning people who inject drugs. So, and it was pretty much statistically significant. The confidence interval was between 1.17 and 2.03. Also in this study, Lowe et al. Were able to show that opioid substitution therapy was associated with a twofold increase in adherence. And, even though it was it's a meta-analysis that they did, the only thing that I would say about this study, the threshold for adherence was, variable. So as you can see in some of the groups, it was 100% adherence, and then it was also self-reported. So, it can be critiqued a little bit, but I think the general trend that they noted was that opiate substitution therapy was associated with an increase in adherence, and in their study, a twofold increase. Another thing to note is that opioid substitution therapy in their study was associated with almost 50% increase in the odds of viral suppression, and so I think that's very important. I will also note as well that in the study, the threshold was, pretty variable. So in some, 500 copies per ml, others 50 copies per ml, but the general trend was that opioid substitution therapy was associated with a higher increase in viral suppression in terms of HIV. Now, this study here was published in JAMA in 2014. The main thing I want you to take is that in persons that were on maintenance opioid abuse therapy, the incidence of hepatitis C virus infection was actually lower compared to those not on therapy or on other forms of therapy, like non-opioid abuse, on other forms of therapy. So pretty much in this study, they looked at the incidence of hepatitis C virus infection in a cohort, about 550 young adults, and they followed them over time. And they essentially found that those who were on maintenance opioid abuse therapy, that group, they had a lower incidence of hepatitis C virus infection. Now, the million-dollar question. Outpatient parenteral antimicrobial therapy among people who inject drugs. So, it's always up for debate, in terms of patients or persons who inject drugs, what to do regarding, PICC line use and whatnot, because there's always the fear that these patients may go home and maybe tamper with their PICC line. So I tried to see what I could find in terms of some recent literature regarding, what's out there, what are the general thoughts, or what does the literature say. So in this review that was published in Open Forum Infectious Disease, There was only one study in which misuse of PICC line was documented, and that was at a rate of 2%. In the other 3 studies, they said there was no evidence of catheter misuse. However, the caveat was that those other 3 studies, they had more, I guess, more stricter or more extensive protocols. They used, tamper-proof seals, Tegaderm dressing to cover the catheter access port, and they had persons that were doing frequent line inspections. So I think it's up for debate, but this is as most in terms of like recent literature that I can find regarding offering outpatient parenteral antimicrobial therapy and via PICC line to persons or people who inject drugs. So medication-assisted treatment waiver. Essentially, there are 3 FDA medications approved for the treatment of opioid use disorder. These are buprenorphine, methadone, as well as naltrexone. Now, in terms of the steps to obtain the MAT waiver, this is just like a summary of it. It's a little bit more complicated, but I think it's something worth knowing in terms of, especially if you, let's say when you finish the program for S Fellows and you want to go into HIV primary care, this is something that you can actually do. So the first step, you want to, check your eligibility. I mean, you have to have a DEA license, obviously. If not, well, then you apply for your DEI license. Then you have to take an 8-hour training session. To facilitate us physicians, you can either do it online to complete an online 8-hour training, or you can do it half and half online, half in person. There's also a webinar format as well that you can do, or you can do the full 8-hour, full day training in person. And once you've done that, then you want to complete your what they call a notification of intent form. And you submit this online to the Substance Abuse and Mental Health Services Administration. It's very easy to find their website. And after that, you forward your certificate to the same organization, SAMHSA. And after that, you just wait until you hear back. Now, in terms of how long that whole process takes place, I mean, on their website, it says about 45 days. The only thing that I'll say is, at least from my understanding, once you initially get it, there's a certain limit in terms of the number of persons that you can treat initially, and then after that, you have to sort of like reapply again to kind of increase your quota. So that's something just worth noting. So what is being done on a national level? So in 2018, the National Academies of Sciences, Engineering, and Medicine, they had a workshop. And they came up with a 5-step action plan. I'm not going to read everything, but the gist in terms of what they were talking about was that it saw it as it being very important to screen for opioid use disorder in patients that came in with infections. This is where we can also come in. Because these are the patients that we see, patients with endocarditis, bacteremia, skin abscesses, vertebral osteo, HIV, as well as hepatitis C virus infections. So screen these persons for opioid use disorder. And I already gave you the opioid use screening tool. And for those who you've screened and have tested positive, then we want to consider prescribing, effective medication for opioid use disorder. Again, this is a multidisciplinary approach. I'm not saying that you're going to be the one prescribing, but certainly once you've identified a person with opioid use disorder, make sure you make the appropriate referrals or calls to ensure that they can get treated. And then we want to ensure that they also called for, better hospital-based protocols to ensure appropriate linkage to community-based treatment programs. And, increased training. So like increased training in, fellowship programs, residency programs, medical schools, PA schools, nursing schools. And, as always, funding is always an issue, so they also called for more funding. Now, in terms of the Infectious Disease Society of America, as well as HIV-MA and the Pediatric Infectious Disease Society, they also released some policy issues statement, and it was a lot that they released. So this is just really not even, this is just like the tip. But a couple of key points that they made were to expand access to syringe services programs and safe injection or consumption sites, because these have been proven to, lower the risk of, HIV and as well as hepatitis C virus transmission. They also called for lifting arbitrary limits on the number of patients that a physician and other prescribers can treat with medication-assisted treatment, which is like what I was saying before. Initially, when you get your waiver, you have a certain quota in terms of patients that you can treat, and then after that, you have to reapply again, so to speak, to increase that quota. And then again, the funding, but they particularly said that there needs to be more research in terms of determining the scope of prevalent comorbid infections such as infective endocarditis and osteomyelitis in persons with opioid use disorder. So I mentioned a little bit about syringe services programs. They're basically like community-based prevention programs that can provide a range of services, which include, linkage to substance use disorder treatment, as well as access to and disposal of sterile syringes and injection equipment. Interesting fact, I did not know, but apparently police officers, they have a 1 in 3 risk of getting stuck by a non-sterile needle. So that's pretty remarkable. So it's very important that, at least persons who inject drugs, they have access to dispose, of their syringes or whatnot, injection equipment. Syringe services programs, they're not everywhere in the U.S. I couldn't really find specifically regarding Florida. I did see, I can't remember when exactly, I think maybe a couple years ago, I think in Miami they were trying to have somewhat of like a pilot program, so to speak, to address this, but that's as much as I could find online in terms of like what's being done locally. But again, there's lots of legislation and stuff behind the scenes regarding that, so I won't go any further into that. What's the CDC doing? Like I had mentioned before, there was a map that I had shown earlier where they made a note that there are around like 200 plus counties that are increased risk of HIV and hepatitis C outbreaks, so to speak, or increase. So at least they've been able to identify those areas that are high risk, and so certain things are being put into place to help mitigate that risk. The CDC has also tried to help promote school-based primary prevention programs as well to aid with this. So, in conclusion, opioid use disorder is associated with increased risk of infectious diseases, as we talked about today. Screen your patients for opioid use disorder. I think if you screen a patient, you're helping out the patient. And then the other thing is that consider obtaining a buprenorphine waiver maybe at some point in time in your career. And that's it.